Welcome back to the Health 3.0 podcast, where the innovators of the future of healthcare are leaving their insights to help you take control of your health today. So in today's episode, I want to talk about this concept of Healthspan and lifespan. I really want to consider prevention as the new prescription, if you will. In our first episode, we talked a lot about what Health 3.0 is, why the medical system isn't actually broken, it's just outdated. What I want to do today is build on top of that by talking about what's happened, particularly with the providers, particularly in the medical system, as a result of this outdated system that we live in. And I want to talk about how we need to build Health 3.0 from the provider's perspective so that you can understand how to do potentially a lot of it yourself. Welcome to Health 3.0. I'm Dr. Doug Lucas, and I've spent my career working inside a healthcare system that too often waits until you're sick before it pays attention. We're moving past that. We're ready for a new system. We need Health 3.0. This show is for men and women in their 30s, 40s, and 50s who are starting to feel those midlife shifts, that fatigue that creeps in, the weight that's harder to manage. This show is for people who want to take control of their health now. So if you're ready to move past sick care, if you want to know what Health 3.0 looks like in your own life, you're in the right place. So let's pick up where we left off. I was talking about in the first episode that the system's outdated. It was designed to treat acute problems, the urgent need, the deaths of childbirth, the infections, the traumas. And they did a reasonable job in doing that. And now we have the system that we have today with all of its potential flaws, but all of its glorious benefit as well. But as a result of the way that it's developed, we now encourage in the system prescriptions, we encourage procedures. So it's all about patient volume, E&M coding if you're a provider, and it's about procedures if you're a proceduralist, like I was as an orthopedic surgeon. I got paid to do surgery. What the hospital wanted, what my practice manager wanted was for me to do as many surgeries as possible because the system is now built around making money, not so much around providing healthcare, depending on your version of the definition of healthcare. As providers, we are not motivated to or compensated to prevent disease. We're treating sickness, we're doing procedures, we're prescribing drugs, we're not actually encouraging health, we're not encouraging prevention. And as a result of that, we have patients who are polypharmacy dependent, meaning they are on numerous drugs from numerous doctors. We have people that don't look for care until they need a procedure, right? People that wouldn't come to me, again, as a foot and ankle orthopedic surgeon until they needed to have their foot cut off, when there's so much information that could have helped them to prevent that outcome in the first place. And when you look at this from a science perspective, there are actually studies that show that 80% of chronic disease could be prevented by simple lifestyle choices. And what this creates is a system that actually fails both the consumer, because I think clearly people are feeling that right now, but also fails the providers. So the providers are not able to add in this idea of prevention. We're not able to add in this concept of health into our practice because we are golden handcuffed to the procedures or to the drugs that we're prescribing. But this also works true for the consumers, for the patients, because they're also not taught that they can seek health, that they can ask the questions to the providers, because the truth is that now they can't. Maybe there was a time when the doctors really did know enough to actually guide somebody or counsel somebody on nutrition and exercise and all the things that we need to actually promote health. But that time, for the most part, is long gone. Unless your provider is going out of their way, they're doing training outside of their conventional training, their traditional training, and they have learned how to help and built a structure in likely their own practice that can help somebody to do these things. So we have gotten very far apart as both patients and as providers. And again, we need to bring this together. And this is this concept of this Health 3.0 concept for me, where we need to both educate, we need to empower, we need to give independence and autonomy to the consumers, the patients. But we as providers also need to have a way to have at least a practice model, or those of us that are in private practice, a business model where we can actually get paid to pay our employees and keep the doors open to actually provide this type of care. And the chasm between the two is so big right now because doctors really only get paid to do the things that doctors get paid to do in the system. and patients are looking for something totally different, but with potentially unrealistic expectations that aren't going to meet in the middle. So we have to bridge that gap. And what we also need to do is bring the trust back. We need to be able to provide information that is trustworthy, both as providers, but then also look for people who are trustworthy as consumers, as people consuming content on social media, on YouTube, requiring that people are giving some ounce of credibility, some resources, some understanding of where they're getting the information that they're getting. Because right now, again, the divide is so big and it's so hard for providers who are trying to be evidence-based to have conversations with consumers who are listening to people who are not using evidence at all. There is an area in the middle, and we really need to find that area in order for us to start moving forward to prevent disease, to encourage health span, and ultimately, potentially, to lengthen lifespan. But like I said, I'm going to focus this on the providers. So what I saw and what I still see is that over the last really 10, 15, 20 years, there has been a push from a provider perspective to learn more information. That's why we have seen the rise of specialties like integrative medicine. That's why we've seen the rise of functional medicine. That's why we've even seen some other societies like the Menopause Society. We've seen the development of obesity medicine as a subspecialty. There is a new education. There are new pathways that are moving forward, but each of these has their own problem too. So let's talk about functional medicine first. Functional medicine is a really interesting word, and it is, for some people, kind of a dirty, murky space. I have some colleagues and mentors who despise the word functional medicine. But then I have patients and family members who love this idea of functional medicine. So let me just define it loosely because it doesn't really have a good definition. Functional medicine, as I see it, is providing care through an avenue that is looking outside of the conventional reference ranges on a lab, for example. So let's just use hormones, something I talk about a lot. So if you look at the reference range for, let's say, testosterone for a postmenopausal woman, free testosterone, even better example. This is a lab that you can get, blood test. And if you test this in a postmenopausal woman and they look at the reference range, you'll see that it includes the number 0 on the bottom end. 0, as in you don't have any. Clearly, that's not optimal. So the conventional model would say if you have any number above 0, that's quote unquote normal. And it is. It is within the reference range, which is a statistical average of the population, right? But that's clearly not optimal. All of us need testosterone, both men and women. And if you have 0, you're not going to function as well as if you had some. What's optimal? Well, that's up to the evidence and the interpretation by your provider. But a functional then reference range would be higher than that. And we have our own reference ranges. You could look at this another way too and say, functional is part of preventive. Functional includes more complex testing, urine testing, stool testing, looking at things that are, again, outside of the conventional medical model because we can start to incorporate other tools, whether it be supplement or modality or whatever, into the treatment plan. And this is quote unquote functional medicine. That might sound great. And I've worked with functional providers and I've had great outcomes for some things. But it also breeds a really murky space. Because I see some providers that have, let's say, not to pick on chiropractors, but a chiropractor who wants to go through a functional medicine training. They can do that. And I would encourage them to do that. It would improve their patient care, likely. But then you have a chiropractor who absolutely has a skill set, and I'm not belittling that at all. But you have a chiropractor who can call themselves a functional medicine doctor. And this gets really confusing when they start making recommendations that are in their scope, but then the consumer may not understand what that scope is. Again, I see this in the hormone space all the time. A chiropractor who is a functional medicine doctor who is treating postmenopausal women with over-the-counter products that are not adequate to actually achieve the patient's goals, but they don't know that. So then functional medicine can be kind of murky. Add on top of that the challenge around industry in both functional medicine and longevity medicine. This is such a big market. There's so much money to be made that companies are coming to market and offering things to providers and to patients, direct to consumer, that do not have enough evidence to support it, in my opinion. Now, there are some products in the space that are fantastic, but there are lots of products in the space that do not have enough evidence to support them. And I see people spending lots and lots of money they do not have, money they should be spending on something else, on something that has a claim that has no substantiation behind it. Now, all that said, when I left the conventional medical model, I wanted to get out into that fringe. I wanted to learn as much as I could about functional, quote unquote, functional medicine. So I went way out there. I learned some crazy stuff. I, read as much as I could, looked at providers who were having great outcomes and really challenging patient populations, and I took what I could out of that. But then what I did is over the course of a couple of years, I brought it back. And so now myself, my colleagues that I really appreciate and I respect the work that they do, we found a way to kind of bridge the gap, use the best of functional medicine, the best of integrative medicine, and combine it with the tools that I'm going to talk about in a minute to create something that is, again, bridging the gap between conventional medicine and these new terms like functional medicine. I want to talk about a couple of other terms here too that I think is really important to bring up. I've mentioned integrative a couple of times. So integrative is an interesting term. There is an official integrative medicine definition, but we have to remember that integrative doesn't actually mean that there's any difference in training. So a primary care doctor could open an integrative practice that's integrative in whatever. It could be integrative in speech therapy. It could be integrative in occupational therapy and PT. It doesn't have to be anything new. It's just integrative in something. So you need to make sure if you're going to an integrative doctor, you know what they're integrating. The other term that's really important to understand here is concierge. There's lots of concierge doctors popping up, large practices, small practices, but concierge, again, doesn't actually mean anything different from a training perspective. Concierge just means access. And this could be fantastic if that's what you need, but don't expect that doctor to have any additional training just by definition of concierge. They might, but they might not. So if you're not familiar with the term concierge practices are doctors who are generally going to be in the cash pay space, or you pay a membership where you can have better access to that doctor. So it might even be that you have their phone number and you can text them and they'll text you back. Or maybe it's a different kind of call service than another doctor that has a bigger system or whatever. There's lots of versions of it, but access is really important to some people. And in some areas, access is really hard to providers. And so that's where concierge really might actually make sense from a financial perspective. But it doesn't mean that that doctor has any specific training. They have just been inserted into a model where you have better access. So what I'd love to do is just give you an example of how we put this together. Because again, the goal is to look at prevention as the new prescription, or looking at Healthspan versus Lifespan. So let me just define these things real quickly. So Healthspan, again, is the amount of time in our life that we are healthy. We live at our optimal health for as long as possible. That is our health span. Versus lifespan, because lifespan is just simply how long we live. And I've mentioned this before, but I've seen plenty of people who live a long lifespan, but decades at the end of that lifespan are not the way that they want to live. So our goal then is to have a nice, long, healthy health span. And then at the end of that healthy period, we actually die relatively quickly. So then how do we get there? Well, in order to get there, we need to prevent chronic disease, because most of us are not going to die of something acute, an infection or a car accident. Some of us will, unfortunately. Trauma happens, right? Infections that can't be treated do happen. But most of us are going to die of chronic disease, heart disease, cancer, Alzheimer's, frailty and fragility fractures, osteoporosis. That is what's going to kill the vast majority of us, should we live long enough to see that. So then in order to improve our health span, for things not to affect us early, we need to create a framework where we can focus on the things that the literature supports, not so much Instagram or Facebook or YouTube, but the literature supports actually putting action into place. So I have a framework that I've been using for the last several years that I'd like to bring forward today, because this is something that providers and consumers, patients alike, can use as a way to frame what they're going to aim at. So I call this the health optimization pyramid. The health optimization pyramid is very simple. This is a simple framework, and probably every functional medicine or integrative provider has something that looks like this, right? Some pillars of health. And usually they're either identical or very much the same. But let me run you through this one. So on the bottom of this pyramid, we have 4 pillars: nutrition, exercise, sleep, and mindset. Depending on what you're optimizing for, these pillars are going to look different. Now, of course, there are similarities, right? The optimal nutrition approach for someone who is looking to prevent heart disease, dementia, maybe cancer, osteoporosis is going to look very similar, right? Some of these things are going to be the same across the board, like eliminating ultra-processed foods as much as possible, eating a low-inflammatory diet. But there's a lot of variation in there, and you can do, again, whatever it makes sense for you from a belief perspective. There are cultural considerations. There are religious considerations, right? There's environmental considerations. So I don't like to get specific unless we have to on a particular type of diet, but nutrition is a cornerstone. It has to be included in this plan. The exercise piece is a little bit more complex, but has to be included. This is where, depending on what you're optimizing for, it might really change. So let's say you're someone who is very overweight, someone who is, has a BMI that's very high, you have obesity by definition, and you really need to lose weight. The exercise that you're going to do versus someone who is underweight, who is struggling with osteoporosis, who is trying to build muscle and bone, those plans are going to look different. They're going to overlap though. They're both going to include resistance training, but they're going to have differences. And so this is why I can't give you prescriptive. This is why it has to be unique and customized to you. But some type of exercise, movement, getting away from the sedentary lifestyle that we all live. Number 3 is sleep. I'm going to talk a little bit about this. I hope to have some great interviews on sleep in the future. But here's the thing about sleep. Sleep is critical. Sleep is really interesting because we don't understand really why we sleep. It doesn't make sense that we would spend a third to, for some people, half of our lives in an altered mental state where we can't protect ourselves, right? Like, it does not make sense that we, over the course of, millions of years, we have preserved sleep in nearly every species, whether it be a mammal, an insect, in the water, on land, everything sleeps. Now, there's some funny little unique things like giraffes don't sleep for very long. I don't understand why. Dolphins and I think some other mammals in the water sleep one half of their brain at a time. Like, sleep is strange that way. But even insects sleep. So again, we don't really understand why we sleep. So it's easy then to pull away from sleep when we're overloaded. We have all these things that we want to do. We're feeling stressed out. And it's so easy to say, well, I'll just sleep less. But we all know that if we sleep less, we don't feel as good. I mean, it's easy to live in that state for long enough where you can say, oh, no, I'm just one of these people that I do great with 5 hours of sleep. I lived like that for years. As a surgeon, being on call, interrupted sleep, and I thought, no, I'm good. It turns out I was wrong. I actually do need 8 hours of sleep. When I get 8 hours of sleep, I feel amazing. But I have patients, family members, that need more than that, right? I tell people, some people, when you start looking at their sleep habits, you actually need a 10-hour sleep window. Because without 10 hours, things go downhill for you. You need a 10-hour sleep window. It drives them nuts, but it's true. So we have to protect our sleep. The literature is absolutely clear. If you short sleep, which by definition is anything under 7 hours, by the way, 7 hours, that's the low end. If you are short sleeping, bad things happen. Metabolically, you have different cravings, you have higher cortisol, you make different food choices. Short sleep is associated with all kinds of things like heart disease and dementia. So sleep is a big deal. But here's the funny thing about sleep. When I tell this to people, usually they say, oh, okay, so what supplement should I take? Or what medication are you going to prescribe? That's not the answer. Sleep is all about lifestyle and potentially hormones for postmenopausal women. But for the most part, it's about lifestyle. It's about sleep hygiene. It's about having a very clear bedtime, a very clear awake time, and keeping this consistent every day of the week. Yes, I said every day of the week. This idea of social jet lag, of getting up at 5 on weekdays and then sleeping until 10 on weekends. That's like flying halfway across the world every weekend. It's terrible for your body and for your brain, right? So this idea of social jet lag needs to be at least minimized. I get it. I do it too. But I try to minimize it to within less than an hour. Some very simple things like having a TV in your bedroom. Oh my gosh, get the TV out of your bedroom. Do not watch TV while you're in bed. Do not watch the news while you are in bed. It's like training your brain that you're running from a tiger while trying to go to sleep. It's not going to happen, right? Your phone needs to not be actually in your room at all if possible, but definitely not by your bed, right? Your room needs to be dark. It needs to be quiet. You need to get all distractions out of there. That includes your dogs and maybe even your kids. Yes, I said it, your kids. All of these things are very simple, but some of them are not easy to do. And understanding which ones are right for you usually takes talking with someone who understands sleep really well, even though, again, these things are simple. You could buy a book and read it, but it's hard to implement it sometimes. Behavior is difficult to change. And then the fourth pillar is mindset. Now, mindset goes across everything. And this pillar for me has actually been called several different things. It's been called stress mitigation. It's been called social connection. But ultimately, I think right now, at least, I wrap my mind around mindset because mindset is the key to having the right sleep hygiene. It's the key to feeling like you're going to exercise and feeling good from exercise. It's the key to every single decision you make around what you eat. Mindset is huge. Understanding how to improve mindset, not easy. Takes the right social circle, takes the right people, takes the right information. It's possible to improve your mindset. So that's the foundation. And then from there, I've struggled in the past about saying which one of the next things is more important. What is the next lever to pull? Over the last several years, because I've been focusing on especially postmenopausal women's health, talking about hormone replacement therapy in both women and men, I now really spend a lot of time talking about hormones and the importance of hormones. So for me, after lifestyle, I say hormone optimization. Now, that doesn't mean replacement in everybody. In fact, really, on a big population level, it doesn't mean replacement in most people because a lot of people don't need replacement, they just need optimization. And this concept of optimization is totally foreign to a lot of people, so let me just explain it. When I talk about optimizing, this is where, again, I'm leaning into functional medicine a little bit. But when I say optimizing hormones, I mean, again, it's whatever you need to feel your best, to perform your best, sometimes to look your best, depending on what you're talking about, depending on what your goals are. When it comes to optimizing hormones, it actually easiest way to think of this is with men. So with men, most men, if they talk about hormones, they go to their doctor and their doctor checks the total testosterone and their total testosterone is quote unquote normal and you're fine. Whatever you're feeling isn't coming from your testosterone. That might be true, but it might not be true. Because we see men who have testosterone levels that are still normal because, again, the reference range is huge. Depending on the lab, it could be from 900 down to between 250 and 300. That's a massive range. And so if you are on the lower end of that range, and especially if your free testosterone is very low for some very specific reasons, you could have terrible symptoms of low T and not actually have a diagnosis of quote unquote hypogonadism, which is the medical term associated with true low testosterone as defined by the related medical societies. So optimization then could be utilizing something, whether it be lifestyle, whether it be supplementation, whether it be some kind of pharmaceutical or potentially just testosterone replacement in improving that total testosterone, even though it's quote unquote normal. That's hormone optimization. Now you can then extrapolate that through hormone replacement therapy for postmenopausal women, for perimenopausal women, for premenopausal women, across the entire population. And this is why I say it's so important. So for each of those three female populations, for premenopausal women, understanding that cycles are important. Menstrual cycles are important for your health. What's happening with your estrogen during the first half and with your progesterone specifically in the second half, are you ovulating or not? All of these things really matter. If you're having symptoms around your cycle, understanding what is going on, is there something that could be optimized under that scenario? And if you're not having normal cycles, is there something that could be optimized? Is there something that could be improved? Because not having normal cycles can lead to a lot of downstream things. The one I talk about a lot is bone health. There's a study I looked at a couple of years ago that showed that if you weren't having 5 quote unquote normal cycles, if you weren't ovulating 5 times a year, then you're losing bone as a premenopausal woman. And that's a big deal. And there's a lot of others too. For perimenopause, oh my gosh, this is an area where there's a lot of discussion to be had. How do we optimize hormones when they're rising and they're falling and they're erratic and menstrual cycles are all over the place, they're short, they're long? It's possible. There are tools. It's not easy. And then for postmenopausal women, having this discussion, is HRT right for you? It's not right for everybody, and that's okay. But definitely having this discussion with all of the information that we can assimilate, all the information that we can put together, your unique risk factors, and then deciding what's right for you. That's hormone optimization. And then the next step up from there is biomarker-driven supplementation. Now, the supplement space is wild, and I've talked about this before, so I'm not going to get into it today. But just know that there are infinite supplements that you could take. You could spend all of your money on supplements and potentially see absolutely no benefit. So this needs to be biomarker driven, and that's either serum testing, that's functional testing, that's genetic testing, or it's just looking at what you're missing in your diet and then using the things that make sense for you for the period of time that it makes sense for you. Probably going to need to work with somebody on that one. And then above that, we get into pharmaceuticals. we get into, some of the cool longevity stuff or conventional medical model stuff, cardiovascular prevention through lowering LDL or whatever, like whatever those things are. That for me is at the top of the pyramid, not because it's better, but because we need to do all the other stuff first. So whether or not we're considering using a drug for cardiovascular prevention or, for whatever long-term thing we're talking about, we need to focus on all the other stuff first. And here's the problem. As I mentioned earlier, doctors don't get paid to talk about those things. And actually, they're not trained to talk about those things anyway. So how do you put together a team of experts in that space that can provide the resources that you need to put all of that together? You have to be involved too, but you also have to have the right resources at your fingertips. So then as this new layer is being built on top of the old system, some of the fun things that come to my mind are, what is the future of AI in healthcare? We're going to have some great conversations about that with some experts in the space. We're doing a lot of work at LifeMD on the back end with AI right now, and I can tell you that the future is going to be really interesting. It's going to really help us to bring quality care at scale in an affordable way. And I'm really looking forward to sharing some of that with you. Some other fun topics are going to be around insurance. Insurance is both frustrating, but also kind of important in our current marketplace and our current conventional system. We want to work with insurance companies as we build a new system because it's very expensive. If any of you try to get into the functional space, man, it's expensive, right? And as somebody who built a company around it, I can tell you that a lot of times these companies are not making money, even if the product is really expensive. So it's generally not that the owners of these companies are raking in a lot of dollars. It's very expensive to run. So we want to use insurance where we can. We want to engage with Medicare, Medicaid, so that we can provide better care. We can provide Health 3.0 to a much broader audience, right? We want this for everybody, which brings me to the idea of policy. I haven't mentioned this yet, but one of the things that I really want to get into is policy around healthcare. We have to decide as a country, is healthcare a right or is healthcare a privilege? And interestingly, there's a lot of debate on that. We have to decide if healthcare is a right and everybody has access to it, how do we pay for it? What is the system going to do to be able to afford all of us to get the right type of care? Nobody has an answer to this question that I found yet. But as we have stars moving up into the political realm, I want to have them on the podcast. In fact, I'm inviting them right now if they're listening to this, or if you know them, I want to have these conversations openly to discuss what the future policy of healthcare looks like. We need to be creating a system that can incorporate the tools that we need to use to prevent disease, not just keep the system as it is or continue to kick the can down the road to just stick a Band-Aid on it, just keep rolling it down the road because it's a moneymaker. We know it's a moneymaker. We can't shut it down or the country would go bankrupt, actually. So we have to build on top of the system and do it in a way that is fiscally responsible. How are we going to do that? But beyond that, we also have to understand that insurance companies are not going to pay for everything. It is not reasonable to think that an insurance company is going to pay for your food, for example, right? Insurance companies are probably not going to pay for your trainer, although sometimes they do. They're not going to pay for you to do a lot of the things that are going to excel you in the Healthspan race. They're not going to pay for some of the things that you want to do that are considered to be elective, the supplements, the biomarkers for the supplements or the genetics maybe. So we have to understand that we as consumers are also responsible for our health. We as consumers also need to invest in our health with the ability we have, with the resources that we have. And that's going to be different for everyone. So what I see in this vision of Health 3.0 is a network of people. I don't want to just say providers, because providers generally means nurse practitioners, PAs, MDs, DOs. Generally, that's what people mean when we say providers. But it's more than that. We can't rely on the providers to bring this type of information. We are simply not trained to. We are not experts in everything. So then we need to have access to the exercise physiologists, the dietitians, the actual trainers, the experts in sleep, the health coaches. We need to have access to all these resources in a way that, again, is right at our fingertips. And again, as we build this, we need to focus our energy on prevention, not on treatment of disease. We need to prevent disease, and we need to create a system that encourages providers and all the other people that are part of the network to actually make a living preventing disease, rather than this system of just treating disease and getting paid for prescribing, for time with patients, or for procedures, we need to incentivize outcomes. And some of this is happening. In fact, if you look at some of the longevity research out there, we see that some of the best predictors of health span and lifespan are things like grip strength, things like muscle mass. We're learning that VO2 max, which is something that you can train, is a better predictor than, say, your LDL cholesterol, which is something you'd write a prescription for. So we are doing the research. It's happening. And now is the time we need to act to start putting it into play at scale for the population at large. Because the future of medicine is not just about living longer, it's about living stronger. We need to see, as we're seeing this rise of these new specialties, functional, integrative, whatever it's going to be, we need to bring these things forward, but with this bigger picture in mind. They can't just be a duplication of what they came from, right? They can't just look like the system as it was and focus on pharmaceuticals and procedures just with a smaller scope. We must have a bigger scope. We must be inclusive of all of the other people that are bringing skill sets to the table. So if that sounds great and you're ready to get started, don't fire your doctor just yet, because this has not been built. There are plenty of practitioners, like I built a practice where this was all in place, right? That health pyramid I just described was my practice, but we could only serve 300 people. This is a much bigger problem. So don't fire your doctor just yet. Just know that we are, with the people that we're going to interview on this podcast, with the people that we're working with, especially at LifeMD and elsewhere across the country and across the globe, we are building this. The innovators, the leaders, the technologists, the experts in the space are building this, and it's a very exciting time. And I look forward to bringing that to you episode after episode. So that's it for today. Please remember that life should be about acquiring memories and aging with strength and grace.